provision in our facilities. And to help us discuss that, we have our very own Dr. Kakungu Simpungwe. Dr. Simpungwe, kindly confirm that you are on the call now from the Ministry of Health, Assistant Director, to give us a presentation. And we'll have experts on the panel that will help us appreciate adolescent health service provision. Among them, Mr. Ntula Simwinga, Dr. Chaliwe Chungu, Dr. Bupe Musonda, and Dr. Robert Banda. We'll also have a case that will be presented later on from Matero by Ms. Prudence Mlambia. So I encourage all of us to participate in this presentation and also share some best practices as we will learn from the case and see how we can improve adolescent health service provision. So without wasting so much time, I'll now invite Dr. Kakungu Simpungwe to give us the presentation.
Good afternoon, everyone. Thank you so much for inviting me to make this presentation. So I'll try to be as brief as possible, but also to ensure that the key issues that service providers need to know and the skills they need to acquire are covered in this space. The amount of time I've been given. How long should I speak for? How many minutes do I have to speak? Hello?
You have 20 minutes.
Thank you so much.
20 minutes.
Thank you so much. So next slide, please. Next slide. Yeah, so I think this is just a general introduction talking about this special group we are concerned about, 10 to 19-year-olds who are very inquisitive, challenged with the transition they are going through and whatever challenges that period brings with it. Next. Next. So I was thinking maybe we go back. We go back. I don't know at which point we are going to administer the poll, the first poll. Because I can see answers here.
We'll right away go into the poll and
yes,
yes, the network will choose the correct answer. So it's all that applies. So we'll launch the poll after I go through the question. So the following are health. Yes, the following are health problems of public health concerns affecting adolescents. So dear network, do we feel like HIV and STIs affects adolescents, gender-based violence, non-communicable diseases, mental health problems, teenage pregnancy, and malnutrition? So we have to select all that applies. So do we feel that teenagers are affected, adolescents are affected by teenage pregnancies? Is it malnutrition, HIV, or GBV? So we have 53 54% of the network that have polled. Just give a few seconds before I close the poll. Okay, so I'll end the poll, and from the network, most of the people think adolescents affected by HIV and STIs. Some feel mental health, about 10%, and others feel 9% are affected by teenage pregnancies, with a few thinking NCDs and malnutrition. So, Doc, you speak to the challenges as we go to the next slide.
Thank you so much. We can move on to the next slide. So based on the statistics that we have as a ministry and also research globally, these are the problems, health problems that affect young people and adolescents inclusive. They are not the only problems, but these are some of the concerns that we focus on as a ministry. So HIV, STIs, teenage pregnancy, GBV, gender-based violence, non-communicable diseases. So we are talking about issues to do with, for example, sickle cell anemia, rheumatic heart diseases. We have mental health and substance use, as well as obesity and undernutrition. So these are all problems that affect young people. Next. Next slide, please. Yeah, so these are some of the statistics that we captured from the latest Zambia Demographic and Health Survey in 2018. Our concern is the percentage of girls and boys who have access to platforms where we disseminate information on health. So the survey revealed that 47% of girls and 35% of boys have no access to media at least once a week. It means almost half of 50% of our adolescents don't watch TV or radio or even read newspaper. So sometimes when we are very comfortable reporting that we are disseminating information through radio programs and television, we should bear in mind that we are reaching less than 50% of our target population. So this limited access to information has implications. If we look at comprehensive knowledge about HIV, we still have only 40% of girls and 38% of boys with comprehensive knowledge on HIV. So they don't know how HIV can be prevented and when they are at risk. So we really have a problem. So information, access to information, as well as the consequences of not having adequate information is health illiteracy, and that is what we are dealing with. And the statistics also indicate that we are still very high with teenage pregnancy, which is at 29%. So why are we paying attention to adolescents? We want to invest in them now so that they are healthy now as adolescents. When they grow up as parents, they also enjoy that healthy life, and they will also transmit positive or good health behaviors to their children. Next. Next, please. Next slide. Next slide, please. Yes. So the second poll.
Yes, we'll have our second poll. And our second poll reads, how can we encourage adolescents to access health services at the facility level? Select all that apply. Is it A, by being friendly or having a positive attitude? Is it maintaining confidentiality? Is it providing privacy? Or is it D, reporting them to their caregivers every time they come to the facility? So our poll has been launched. And we can select all that applies. So we have a good participation so far, with 42% of the network polling. Let's keep sending those responses. How can we encourage adolescents to access health services in our facilities? Is it by being friendly? Is it by maintaining confidentiality? Is it by providing privacy and reporting them to their caregivers? Okay, so I'll end the poll and share how the network has polled. So 94% of those that polled feel we can encourage adolescents by being friendly. 77% felt we needed to maintain confidentiality, and 73% felt we needed to provide privacy. And we had a small percentage that thought we needed to report them, that 6%, and then 64% felt having flexible operating hours encourages adolescents. Dr. Simpungwe, over to you.
Thank you. Thank you so much. We can proceed with our presentation. So what are adolescents looking for? So these are some of the recommendations from young people. Globally, even here back home, they want a welcoming facility to be attended to quickly. They don't have the patience, actually, even the confidence sometimes to sit on a queue or to stand in a queue to wait for others to be seen before them. So usually they want to come to the facility, they attend it too quickly so that no one notices that they're at the facility, and maybe that may avoid the suspicion that they will be reported to their parents. Privacy and confidentiality, very important to them. And they don't want parental consent or permission, because there are some issues that they don't want their parents to know about, especially issues to do with sexual and reproductive health. Then they also want convenient place at a convenient time. Some of us close our facilities during lunch time because we are having our lunch, and maybe that is the only time a young person can come to the facility. We knock off at 16, we close the facilities. We are not willing even to stay for maybe 30 extra minutes just to provide that opportunity for learners, like those who are knocking off from school, to come through. So they want convenient place, convenient time. Staff to treat them with respect and not to judge them. And they also want us to be knowledgeable, yeah? So have an idea of different services, concerns that they have, especially the list of focus areas that we talked about. Where possible, please provide the services within the same facility. And if you are to refer them, you do it in such a way that they don't feel they have to start from zero or from scratch when they go to the next facility. Next, please. Next. Next slide. Yeah, so what we are focusing on now as a program, realizing that we may not have all the resources to train our health workers in adolescent health. Training health workers in adolescent health is a costly undertaking. The training takes about 6 days. And looking at the monies that have been spent so far and the numbers trained, we are around maybe 3,000 health workers trained in adolescent health. So what we are proposing, like what I'm doing to you now, is just to give you some some skills, yeah, knowledge on the do's and the don'ts and how best we can transform our facilities so that they become adolescent friendly. So our aim to make this presentation is to ensure that as many health workers as possible are sensitized on how to handle adolescents, especially when they seek health services at our facility. When you interact with young people, normally they don't talk about, no, you don't have adolescent health spaces. They will say the services are not friendly, health workers are not friendly. So this is the main reason for making this presentation. So there's what we call the HEADS assessment approach. These are, the HEADS is actually an acronym of what I'll talk about later. So we will look at how we address adolescents, what questions we ask, and the heads will focus on looking at the home environment, the education of this particular adolescent, activities they're involved in, whether they use drugs, sexual activity, as well as the suicide. So the HEADS, if you look at the last bar there, that is what those letters stand for. So next slide, please. Next slide. So when a young person comes to our facilities, like they've really overcome a lot of obstacles. They can't wait anymore. The problem is big. Sometimes the problem may not be big, but they're just trying you for the first time. They want to come and find out how maybe their problem can be solved. So we are saying, can we go back to basics? When a young person comes to your facility, please find out about the environment they are living in. Why? Because we know young people don't live in isolation. Their behaviors, their diseases are actually influenced by the environment they come from. So from home, we can ask questions like, where do you live and who do you live with? Tell me how you relate with other people within the home. So in short, we just want to know whether this adolescent is happy at home. Yeah, is this an orphan we are dealing with? Is it a child-headed home? I think the responses will give us an idea as to whether the environment this young person is coming from, the environment at home, is protective or is at risk for public health concerns. Next. Next. Next slide, please. So we can also ask questions on education. For example, how is your performance if the adolescent is in school? If they're not in school, it will also be interesting to find out why they are not in school. Maybe they are orphans, or they dropped out, or they were pregnant. It will give us an idea as to whether the environment in school is encouraging, protective, or there are issues there which we can address as we interact with them as health workers. Have you ever repeated a grade? Again, we want to see if there's something maybe affecting this young person. How do you relate with your teachers and fellow pupils? So we are encouraging assessment of environments that affect the performance, the well-being of young people. So the home and the school. Next. Next, please. Next slide. Then activities. What do you do for fun? Yeah, alone or with peers? Again, we want to ascertain whether this is a loner or there are signs of depression or they are all over the place and really not involved in productive activities. So again, the main purpose is to assess the environment. Is it protective? Is it a risky environment for health outcomes? So which church do you go to? Do they play any role? So we just want to see if they are involved in productive activities that will help them maybe focus on things that matter the most. How much TV do you watch daily? Your desired show. Next. So is this an active adolescent or withdrawn adolescent? Issues with drugs, again, you tread carefully because you can't just say, do you use drugs? No, they'll say no, because they don't know your next question or your next reaction. So what drugs or substances exist in your area? So from the response, you'll be able to know whether this adolescent is also using drugs. Which one do you use? Again, the response will determine whether they are telling lies or not. I think by the time you're talking about drugs, you would have built rapport with this young person that they're able really to open up. How often, if they use drugs, how often do they do that? Next. Next slide, please. Then we go to the first S. So we've just covered the home, education, activities, the drugs. We go to sexuality or reproductive health. So the questions you ask the adolescent will depend on the responses they give you. What is important is for us to think about these activities or environment so that we are able to ascertain how safe the adolescent is in the community. So with issues to do with sexuality, do you have a boyfriend or a girlfriend? They'll tell you how many do they have. Are they involved in sexual activities or do they abstain? So we probe, and depending on the response they'll give you, you know the advice to give and the service to provide. Next, please. Next slide. What do you know about abstinence? Yeah, about protection. What do you know about safe sex? So the information this young person will give you will help you to know which gaps exist. Remember, we're talking about low literacy levels. So the responses these young people will give you will help you to know what type of information they need so that they make informed decision. Next. Next slide. Yeah, so sexual reproductive, again, we find out if they are sexually active, are they using contraceptives? And for female adolescents, we want also to ask about the last menstrual period. Imagine you've been talking to this young person about drugs and the home environment, and you say, okay, so now what's your problem? They'll just say headache. But if they are pregnant and they've come because of that problem, if you ask about their last period, I think they'll see that as an opportunity to open up. So offer a pregnancy test or contraceptives. And those who are pregnant, we also advise that they go for early booking for antenatal services. Next. So in short, we are saying we think about all possible problems that young people face, and we ask them questions systematically so that we're able to provide the appropriate services. So any lower abdominal pains, now we are screening for STIs. Yeah, sometimes they'll come with a toothache when in actual fact they are having a discharge from the private part. Do you have any sores? So you ask specific questions, you receive specific responses. So provide information on HIV and STIs, depending on how this young person will respond. For male adolescents, please offer VMMC as a preventive measure for STIs, for HIV. Next. Next slide. Then we are also encouraged to remember that there are adolescents who are depressed. They may have suicidal tendencies. this. So we ask about the answers relating to killing. If you don't ask, you won't get the responses. So we need to be deliberate and systematic just to ensure that we get the information that we require to provide the appropriate services. Next slide, please. Next slide. Yeah, I think these are different questions you can ask just to assess the levels of depression if it's there. Next. Anxiety, again, you ask why are they anxious, why are they nervous, and then based on the responses, you can provide the guidance that this young person requires. Next. Next slide. Then we are also, so apart from the heads assessment, if you noticed, what we focused on was the environment. Then we went into SRH, then suicide. Now we know that GBV is also a problem that affects young people. So you also assess for GBV. Yeah, there are signs you can look out for. The patient will be fearful, for example, and downplaying some injuries. No, I just feel when maybe in actual fact they were maybe battered by their partner or their parents. Then based on your assessment, you provide health information and the relevant services, including referral for GBV services. Next slide. Next slide, please. So nutrition assessment, again, we are saying we've seen an increase in the number of adolescents who are overweight. We assess for BMI and also provide appropriate information for them to adopt healthy lifestyles. Next. Next slide. So remember, we again talked about NCDs or other diseases, in fact, including even infectious diseases that affect young people. Please, we need also to look out for these other diseases. I know young people are considered to be healthy, adolescents are considered to be a healthy population, but they also suffer from TB, so we can screen for TB. Just ask some few questions: sickle cell disease, diabetes, and HIV. We just find out if they already know their HIV status, they're living with HIV. And depending on the responses and the findings, we provide health information and the relevant services, including referral. So if your facility is not able to tackle, for example, sickle cell, know where to refer the patient, or diabetes, at least have contacts, direct contacts you can refer the adolescent to. Next slide.
Thank you so much so far, Dr. Simpungwe. We'll go into our third core. So our third core reads, what behaviors must health workers avoid in consulting room when attending to adolescents? What behaviors must health care workers avoid in consulting room when attending to adolescents? Is it being too busy or doing other things, sharing information with others, shouting or lecturing, being in a hurry, or be a good listener? What behaviors must health workers avoid? What should we avoid? Select all that applies. So far, so good. We have about 35% of the network voting. We are 327 on the call. Please let's participate in the poll. so that we are able to assess ourselves. How are we handling adolescents as we are in the consulting rooms? Okay, so I'll end the call and share how the network has fought. So this is how we have fared. Most of us feel we don't need to be busy or doing other things. We should not share information with others. We should not shout or lecture the adolescents, and we should not be in a hurry. However, we have a very small percent, about 4 people from those at Port, who felt being a good listener was was something that a healthcare worker should avoid. So I'll stop sharing and we'll continue, and we'll learn as we go with the presentation. Over to you, Doc.
Thank you. Next slide. Yes, so these are the recommendation. What are the do's during consultation? So remember, this young person or adolescent has left their house. They've overcome all obstacles. They don't mind if anyone has seen them enter your consulting room. So when they are in front of you, what are you supposed to do? So number 1, be a good listener. Stop other activities. Give attention. So these phones we have and headphones, I think they are not doing good, not only to adolescents, but also other clients. So adolescents want to know that they are very important and you are giving them attention. So be a good listener, ask honest questions, control your reactions. Okay, so at your age, this is what you have done, and look at the words. So whatever you see, please, we are being encouraged to control our reactions. Yeah, ensure, otherwise they'll stop responding or even giving you honest answers, depending on how you react. Ensure there is privacy. I don't know if we have changed now. I remember when I was doing my internship, sometimes you have one table with 2 clinicians screening 2 patients, one sitting on one side, the other one on the other side, sometimes just in the corridor, and you are asking questions to an adolescent, you won't get any honest answer. So let's ensure there's privacy. We close the doors, be empathetic, reassure confidentiality. So you are welcome in this, during our discussion, whatever we discuss will remain in this room. They need to hear that from you and be warm. So these are the do's in the consulting room. And I think all of us have failed in this area. We need to improve. This is the reason why we don't see young people coming to our facilities. So they don't need a special building. They just need our good attitude and also to observe what we are guiding you on. So they don't avoid too much writing in the presence of an adolescent. Remember, there were so many questions we were asking about the home environment, the school environment. You can just have it like a conversation without writing each and every response. You can write afterwards. Otherwise, they become very suspicious. So what are they writing and where are they going to take all this information I'm sharing? So they should feel that you are discussing actually, not like is it a reporter or a journalist? No. So don't take the first complaint as a true reason for seeking healthcare. So they'll come with headache, with toothache. They'll come with the very, very flimsy reasons why they've come. So if you don't ask them or screen them systematically, you allow an adolescent who is bleeding to go back home only to be brought back as a BID. So don't believe when they say they've come to your facility because they have earache or whatever. That may not be the real reason they are there. So don't take the first complaint as a true reason why they've come to seek care. Don't lecture them. Don't talk down to them. Yeah, that's what they want. Yeah, don't tell others. Please, if they hear that what they shared with you or shared with another person, that will be the last time you see them, and word will go around and all adolescents won't come to your facility. Then don't get emotional or take things personal. Next. Next slide. Next slide, please.
So we have our fourth and last poll question. And the poll question reads, how can we make hospitalized adolescents comfortable? Do we need to maintain privacy? Do we need to share information with others? Sorry,
The different. This is for the third one. Eh?
Sorry about that. We'll reshare.
Okay.
Okay, so apologies. The poll was there. The fourth poll was not uploaded, but maybe I can just read and then we can discuss as we go.
Okay.
Do we need to privacy? Do not maintain confidentiality. Use appropriate equipment and provide reading materials. So, what is it we need to make hospitalized adolescents feel comfortable? So apologies, the poll was not uploaded.
Okay. Okay, it's fine, we can proceed. So we were discussing our behaviors and the do's and don'ts in the consulting room. So we just added a bit on what adolescents who are hospitalized want to see in us. Again, privacy comes in. During examination, they are so sensitive, their bodies are changing, and they're not comfortable really undressing in front of everyone. So confidentiality again comes, is also number 2 here. Peers, where possible, provide health services admission in a setting shared by similar age patients for support and socialization. So what we are saying, if you don't have like a separate ward for adolescents to be admitted in, you can maybe group them. Like if you have maybe the 15 to 19, if you have patients in that ward, put them together so that they can socialize. Very important for them, and they are a bit more free to be around their peers than to be next to a grandmother and an auntie and things like that. So this is what we are talking about. Where possible, let them be together in one corner as patients. Then, of course, we should remember we are doing very badly in this one. Some of them are learners. They are in school. Why can't we ensure that work is brought maybe to the hospital or to the clinic so that they don't lag behind in terms of schooling? So provide relevant and age-appropriate information. Oh no, this one is talking about educating them, like providing information. Remember, sometimes we just provide services to our patients without informing them on what exactly we are doing and why we are doing it. So this one is talking about that. So inform them about the rights. It's their right to ask questions, yeah, and promote, yeah, the education, what I talked about the last bullet. Next. So the education is on health information, on what you are doing with them, as well as their schooling needs. Then physical needs, ensure equipment used on adolescents is of the right size. Let's not use big pieces of equipment or pediatric equipment on them, so that at least they are comfortable. Recreation needs, where possible, please, let's provide some materials just to keep them busy. Some reading materials, some magazines or books or newspapers, I don't know, at least something. We can do that as hospitals. Next. Families, I think we are doing well as a country. We allow families to support our patients they are visited. And then sometimes we may think just because they are feeling better now and they are adolescents, you can now start sending them on errands as a health worker. We need to also protect them as patients. Next. And when we are changing shifts, they want to know why, okay, I'm leaving, this is the new person who look after you, so that they don't feel vulnerable or become suspicious. So the take-home message to all of us, in order to provide adolescent responsive health services, health workers need to exercise patience. So if you are in a hurry, you won't get anything. They need to be comprehensive in the way they are screening patients, systematic, so that you get the information you need to provide the right services. And health workers should also understand and respond to developmental and social needs of hospitalized adolescents. They need to read, they need to socialize with their peers, and they also need to be made comfortable and enjoy their privacy. I hope this is the last slide. Next. Next. So adolescents are young people, in conclusion, affected by various health problems. They are unlikely to talk about their concerns during consultation, and so services do not meet their needs because we are in a hurry and we don't have the skill. So you won't meet their needs. So skilled health workers in adolescent health are able to transform service delivery to meet young people's needs. So we want to change the narrative. Currently, we have a very bad name among adolescents. Our attitudes are bad, a lot of things are wrong. So we want, with these skills, the information I've shared with you, we want them to say something good about us. We are kind, we are friendly, we are confidential, and we are available and flexible. We don't close our facilities at 16 and are not even able to, we're not willing to bend even a bit to entertain them. Thank you so much.
Sorry, Doc, your network seems to be breaking.
Okay, so the conclusion I was saying, adolescents are young people. We know they are affected by various health problems, and they are likely to talk about their concerns during consultation. Yeah, so we need to have the skills to solicit information or elicit information from them. And skilled health workers in adolescent health are able to transform our services. Our reputation is very bad as a ministry because we are not trained in adolescent health. But with this information, our hope is that we'll be able to attend to young people in a friendly manner so that they are able to continue accessing our services. And we'll go around and we'll see them coming to us, and we'll be able to give them the services that they require. Thank you so much.
Thank you so much, Dr. Simpungwe, for that presentation. I hope all of us have picked one or two things. I personally have learned a lot as a healthcare provider providing adolescent health services. I think one of the things that we lack is the patience, the time to listen to the adolescents, because they will not tell you exactly what they've come for, and they only tell it to you as you go towards the end. So we need patience. I do appreciate the AIDS approach, and I hope as healthcare workers will try to adopt that way of assessing adolescents. Issues of GBV and mental health, I think, are on the rise among adolescents and young people. And it's something that we always have to ensure that we assess the adolescents. let me remind our dear network that for you to access the certificate of attendance, you need to attend at least 90% of the session. So please, let's stick on until 4 o'clock. We have a case presentation, but before that, I'll invite questions and comments from the network concerning the presentation that has been shared. So as we are waiting for comments and questions, we have quite a number of questions in the chat, and I'll just quickly go through the ones that, so I have a question from Dr. Mweemba. Stop sharing this. So I have a question from Dr. Mweemba asking whether there is any research conducted on alcohol abuse and depression in Zambia, and what was the outcome in adolescents. So that's the first question. The second question from Nathan Sinyangwe. It says, it's understood that the use of word sexual has been revised. Just wanted to appreciate the context in which to use the word. I've noticed that some slides are making reference and are stating as sexual reproductive health. I think Dr. Simpungwe will clarify. There was a memo, I think, that went around, and I think it had to do with sexual reproductive health rights. And I think she will clarify on that. Then the third question, okay, how do you assess, sorry, there was a question from Nathan Sinyangwe again on the heads approach in form of a manual, a booklet with some orientation slides. Is there a presentation that can be shared on the heads approach or something that healthcare workers can refer to? Dr. Simpungwe, maybe you can take those concerns and clarify. Dr. Simpungwe, did you get the questions, or Dr. Bupe?
No, please repeat the question.
Okay, so the first question from Dr. Mweemba is asking whether there are any studies that have been done or any research that has been conducted on alcohol abuse and depression in Zambia among adolescents, and what was the outcome? The second one is in the use of the statement sexual reproductive health. There was a memo that was released. Kindly clarify on what that was. And the other one is, do we have job aids on the heads approach, which can be used by healthcare workers, like they can refer to reach when they are assessing adolescents? Thank you.
Thank you so much. On the first question, I hope there will be someone who provide more answers to the question with regards to research conducted on substance use. What I know, as a country, we have surveys that have been conducted to ascertain drug use among adolescents, or maybe even the general population, but not necessarily among the adolescent age groups from 10 to 19. The problem we have is that most of the surveys that we have conducted in the country focus on persons between from the ages of 15 and above. I'm talking, for example, about the Zambia Demographic and Health Survey. There is a bit of information there on, for example, tobacco use. Then we also have some surveys that have been conducted under WHO in schools on tobacco use. I also know that as a ministry, we conducted what we call STEPS survey, and there was an element of alcohol use. But for the STEPS survey, I think the age group was starting from 19. So in short, we have a gap in terms of information on substance use. But I don't know, maybe if there's anyone on the call who has something they can share on surveys done in adolescents on substance use. So it is an area that requires more research and more funding. As all of you may be aware, most of the funding we have, even in research, is focusing on HIV, on TB, malaria, but substance use, I think it's a new focus area even for most of our partners. Then the issue of sexual reproductive health terminology, we are waiting for more information for us to provide further guidance on how we will use this terminology. I think the main concern is the sexual rights, not really sexual reproductive health, but the rights which also include rights of the key populations. So I think the meeting was held and discussed in AU, the issues were sexual rights. And as a ministry, I think we'll provide further guidance on how we interpret this. But for now, the guidance that we've been given is that we use the term reproductive health. You can use reproductive health and rights, but the sexual and reproductive health rights, I think that is what we've been advised to avoid in the meantime. But I think we'll provide further clarity on that. There's a team that is working on the same, so we'll clarify your concerns. What was the third one again? Sorry, Doc, I forgot. The third question, which hasn't.
The third question was the head's approach. Do we have job aids for healthcare use? And then I've got questions. Maybe let me take two more questions so that after you respond, we go into the case. There's a question on what is the position of MOH to adolescents and young girls and women who are below 16 who wish to access family planning without parental consent. Then the other question is, okay, sorry, that's the only one. The other one is just a comment. So you comment on the head's approach and issue of consent for adolescents below the age of 16 who wish to access family planning as well as other services. To you, Doc. Dr. Simpungwe, did you get the questions? Or maybe Dr. Bupe Musonda, you could come through and help us with the response for.
Okay, I'm unmuted now. I couldn't unmute myself. So okay, yeah, with regard to the age of consent, we are still being guided by our legal counsel here. If you all recall, we went round to consult various stakeholders across the country on the age of consent for various health services. The recommendations were shared or sent to the Minister of Justice so that we can be guided on whether or not our recommendations were aligned to the existing laws. So last year, I hope all of you are aware that last year there was an act that was passed, which is called the Children's Code Act. And in that act, we have a lot of statements that seek to protect young people from abuse, including sexual abuse. So in short, the act talks about the rights of children so that they are not abused in any way. And in response to the request we wrote to the Minister of Justice, there was reference to that document, which states that a child is a person who is 18 years and below, and such a person who is a child can therefore not consent to sexual activity. So that is the starting point. And if the person cannot consent to sex, it means they can also not consent to contraceptives. So the guide was, it's like if we say, give this child contraceptions at 16 years, at a child who is 16 years old, we are indirectly saying she can go ahead and consent to sex, which is contravening that act. So we are seeking now guidance on how best now we can interpret that piece of legislation so that we incorporate it in our national health policy. Because as it is now, we are just talking about the letters that were exchanged between ourselves and the Ministry of Justice, but the Ministry of Health through the Department of Planning and Policy will help us now interpret that communication we got from Ministry of Justice into policy so that we have something in black and white in terms of what is allowable, at what age we can provide contraceptives. So that is the response I can give for now. Will be guided and will also put it in black and white so that all of us are speaking the same language. So it's the act that is now like guiding whatever we do, and it's law, so you can't like be above the law, but we'll seek guidance, and I think there are discussions happening in that regard. Sorry, have I forgotten another question? Maybe I'm tired. Is there a question I forgot? Which one did I forget to respond?
You haven't forgotten any. You've responded all of them very
adequately.
well.
Thank you.
There is a question in the chat. I'll ask you if you could respond in the chat so that we can share the case presentation and have a discussion. We only have a few minutes before 16. So there's a question: what advice would you give an adolescent client living with HIV who wants to get pregnant? So kindly requesting that you help us respond in the chat. We have other experts as well, Dr. Bupe Musonda, Mr. Ntula Simwinga, and Dr. Robert Banda. If you could kindly assist in responding to some of the questions in the chat. So we'll have a case presentation. Prudence, are you on the call? Prudence Mlambia from Matero, are you on the call? Can't see Prudence. Okay, Prudence doesn't seem to be on the call. Bernard, you can unmute Bernard. Bernard, you do the presentation, or you're with Prudence?
Yes, Dr. Manzi, I'm with Mr. Bernard.
All right, you can go ahead, Prudence.
Okay, good afternoon, everyone. My name is Prudence Mlambia. the HSS nurse for Matero Sub-District, and I'll be presenting this case on behalf of Matero First Level Hospital. We can go to the next slide. So our case is on female PC, female 19 years old, RVD reactive on ART for 1 year, 10 months. At the time of HIV diagnosis, she presented with a long-standing foul-smelling vaginal discharge. And at this time, she was aged 17 years old. So she described the discharge as watery, non-bloody, and foul-smelling. So due to the bad scent, she was even isolated from her peers, and she wasn't able to interact with her peers and her family members. She gave history of being sexually active, and also gave history of having sex without using any protection with her boyfriend, who was at the time living in another town. She had no other symptoms other than the above mentioned. So she had been receiving health care from a private clinic. She had been receiving health care from a private clinic for an STI before the mother brought her to Matero. So there were no tests that were done at this private clinic. However, she was being given some medication for the discharge. So on drug history, she was receiving an unknown injectable antibiotic and doxycycline. In social economical history, she's the firstborn daughter in a family of 5. She lives with her mother now in Lusaka, but previously she was staying in Kush with her stepmother and her father. She's not married, and she's a grade 8 pupil. On physical examination, she was alert and oriented to time, place, and person. There was no obvious foul smell at the time that she presented at the facility. She did appear wasted, and she was afebrile. She was not pale. She was not jaundiced. Her weight was 45 kg, and her height was 157. Her BMI was 18.3, which was underweight. The BP at the time was 113/70. And then on vaginal examination, there were no lesions that were noticed on the vulva. The cervix was felt firm, and there was cervical motion tenderness. She also had a foul-smelling bloody discharge on the glove. Urinalysis results came out normal, and the RPR came out reactive. She was referred for cervical cancer screening, and she came out VIA positive. We can move to the next slide. Okay. So on the lab test done on the 27th of September 2022, she had a VL done, and it was showing 30 copies. Another one was done on the 18th of August 2023, where it was showing that where it was not detected. On the regime, she's on TLD. We can go to the next slide. So this was the picture of her cervix at the time that she came. The first one on the left, this was the first picture at the first screening. So we noticed that there were lesions between 6 o'clock and 9 o'clock, and even between 3 o'clock and 6 o'clock. So she was treated using cryotherapy. And then when she came back for a review, the second one now was the picture, the one that looks whitish. There's a picture that came out. So because of this picture, she was put on antibiotics so that they can get a clearer picture. So she was put on antibiotics for 5 days, and then was given a review date of after 2 weeks. You can go to the next slide. Next slide, please. Okay. So 2 weeks later, this was the picture that we got a clearer picture. We can go to the next slide. So on diagnosis and management, the diagnosis for RVD, newly diagnosed with syphilis and VIA positive results. Management, she was started on benzathine penicillin, metronidazole, doxycycline, and Cipro. And she also had the cryotherapy done. She was linked to an adolescent support group, and family planning was offered to this adolescent, but she turned down. She said she only wanted to concentrate on school. She won't be concentrating on boys. So she didn't feel like she needed family planning. She was linked to OVC services, and she's been very active in the Rise Up House. We can go to the next slide. So on our questions, our first question is, looking at what we presented, did we offer the best care, or was our adolescent appropriately managed? And what other services could we have offered to this adolescent and others who remain at risk? And our second question is, how best can we ensure that the adolescent accesses comprehensive sexual reproductive health services, regardless of the type of the facilities that they go to, whether it's private or a government facility? How can we ensure that the services are exactly the same and they are comprehensive? And then the third question is, how can we improve our counseling skills as healthcare workers providing services to adolescents so that we improve the uptake of services such as family planning? Thank you. I think those were our questions.
Thank you so much, Madam Prudence, for the presentation. So Matero has presented a case of an adolescent who's 19, 2 years ago was diagnosed with HIV and syphilis, and also had a VIA positive result when she presented with a false mailing discharge. So this adolescent was started on ART, had cryotherapy, and also was treated for syphilis. However, the facility would like to find out what else could they have done better for this adolescent, as well as others that could be at risk like this adolescent. So I now invite any questions, clarifications on the case as we continue with the discussion. We have a hand from Brian. Brian, you can go ahead and ask your question.
Thank you very much, and good afternoon, everyone. My question is on the sexual partner, because we're aware that this is an adolescent who is sexually active. Did we do any elicitations from the partners? And because we know that syphilis being a sexually transmitted disease, we know that it must have a source. So we haven't heard anything on the partner. And another question is, I heard the team presented that they did viral load, of which it was suppressed. So under recent testing, are we certain that this was a recent infection, or maybe this is a client who has been on treatment, but maybe somewhere not at Matero? Thank you.
Thank you so much, Mr. Brian, for the questions. Team Matero, you could respond. Syphilis being an STI and also HIV, was there any elicitation or indexing that was done for this adolescent, as we heard that this was in Lusaka, or she came from Mukushi where the boyfriend is? Did we make any efforts? And on the viral load, when you look at the results, she was diagnosed in 2021, and a few months later, the viral load was 30 copies. Was this a recent infection, or it was an old infection? Your comments?
So let me start with the first one. Thank you very much for the questions. So for the sexual partners, yes, we did elicit the sexual partners, but she insisted that she only had one boyfriend, who was the same one that was in Mukushi. So she said that was the only boyfriend that she had. And we couldn't really bring the boyfriend here to test him because he's in Mukushi. but we did elicit. And then when it comes to the viral load, if you've noticed, this girl started treatment somewhere in January, and the first viral load was done somewhere in September. And we know that TLD is able to suppress, even if you're a TX new, is able to suppress within even 2 weeks. So the only issue that we don't have is we don't have the baseline results for her. I did try to look around to see if we did baseline, but I think we missed on doing the baseline. I couldn't find her baseline results. But this viral load was done after, that was 9 months after she's already been on treatment. A repeat was done on 6 months, but we didn't get back the results, and we did this one at 9 months. So whether it was a recent infection or not recent, I can't answer for that because I don't have the recent results, but the suppression can be explained by how long she's been on treatment. Thank you.
Thank you so much, Sister Prudence. We have a hand from Shumba. You could go ahead with your question.
Okay, so in the presentation, we noticed that the girl was underweight. What approach was done concerning her nutritional status?
Can we also get Brian's question? Then Matero can respond.
Good morning, good afternoon, everyone. This is a very good presentation material, and I'm glad to the way we actually carried it, especially that it was coming from Rise Up House, which means that there's a very good referral linkage system there. So this is quite good and excellent. But rather, I would like to make a comment on the family planning, where the girl happens to say, no, she's not ready to accept family planning at the moment because she feels she needs to concentrate at school. So an adolescent is a very peculiar being. And in this case, yes, she can say, I've stopped, I'll just concentrate on school because there's a problem at hand. But I feel there is need for us to even probe further, or rather to continue doing the counseling so that at least she can accept the family planning. And not only that, but we also emphasize on the condom use as well, by emphasizing to say family planning, we are not only protecting you from being getting pregnant, but also these STIs that you're actually having. Then apart from that, you know, if I happen to counsel an adolescent and that adolescent doesn't heed to my advice, it's better to refer to the second one who can actually continue with the counseling, because she may not accept after I talk to her, but may accept when someone else happens to talk to her. Thank you so much. I just thought I'd make a comment on that. Thank you.
Thank you so much, Brian. You've actually responded to our third question. How can we improve our counseling skills? I think we need to continue counseling, like you said, talk about other options, maybe talk about condom use, and also refer to someone else when we are not able to convince the adolescent. Thank you so much. There's a question in the chat about the facility having a multidisciplinary team. Does Matero have a multidisciplinary team that could have helped to manage this adolescent? And then for nutrition, what did we do for this adolescent who was underweight? Team Matero.
All right, thank you for the questions. Let me start with the nutrition one. So in my presentation, I mentioned to say this the child was linked to OVC services. And for the OVC services in their package, nutrition is one of those things that they tackle. So they do provide nutritional support. So that she was able to get this from the OVC services that she was linked to. And at Matero, we have so many different organizations, different professionals that are working towards adolescents. So we're able to link them to different services. And then just to react also on, that was a contribution also from Mr. Brian. Yes, when she said no to family planning, our sexual education did not just end there. So as I mentioned earlier, to say she's also linked to the Rise Up House. And when you see some of the lessons, like their sessions, some of the sessions they have in the Rise Up House, most of this is addressed. Most of the sexual education is addressed there, and she's been very consistently coming for those and is benefiting from that. So we've continued to offer IEC and also offer education on this to see if we can also improve uptake of the different services that we have. Thank you. I hope that answers all the questions that were asked.
So much, Prudence, for responding to those queries. Now we need to help Team Matero respond to question 1 and 2, because question 3 has been tackled somehow. As a network, do you feel that the adolescent was offered the best care and managed appropriately? What other services? Earlier on in the discussion and the presentation by Dr. Simpungwe, we learned that there are other things that we need to assess adolescents for, such as GBV and mental health and alcohol. Do you feel Team Matero did justice to this case, or there's more that we could have done? Dr. Musonda, Bupe, what is your comment on the first question? There's a comment from Dr. Kapaya. Thank you so much for the presentation. We could also have tested for other STIs, for example, hepatitis B, and on the cervical cancer, are we going to confirm it as the patient is still being followed up? So maybe Team Matero can respond to that one. And the hepatitis B, why was it not tested? So thank you for that addition. Hepatitis B should have been tested in this case. So any other tests or any other services that this adolescent should have been provided with? I've seen the chat has been very active. Thank you so much, Mr. Simwenga, for the comments and the discussions that are going on there, where there's a response to that question. So the question on multidisciplinary team was not answered. Team Matero, do we have a multidisciplinary team? Maybe Maria, is it Maria? You could just shed more light. Mary Rose, you could shed more light so that maybe Team Matero is clear on what you are looking for in a multidisciplinary team. Maybe others can also learn from that. Mary Rose. I need. Mary Rose, are you able to unmute yourself and just shed more light?
Yes, good afternoon, team. Yes, adolescents are a vulnerable stage of life, and they need to be handled with a lot of expertise from different disciplines. So like here in Mazabuka, where I am, we have such teams. Everyone contributes in the management of such cases. If I can say, adolescents are kind of like chameleons. They will show you what you want to see, and in this case, it is a chronic condition, because there is a suspicion of maybe cervical cancer or something alike. And she's also HIV positive. It would not be like an active palliative care services, but they will be passive according to the symptoms which are presented. in this case, the young lady need to be made like to understand, to come to an understanding of the how the situation is very very much critical, not only for her but also for the people around herself. That's why they need to have a multidisciplinary team, psychologists, counselors, social welfare, maybe relatives, the medical personnel, to tackle all angles of her issue.
Thank you so much, Mary Rose, for clarifying. So when we talk about a multidisciplinary team attending to an adolescent, we are talking of a psychologist, social welfare, nutritionist, psychiatrist. We are talking of the clinical team. Do we have such teams in our facilities? I'm not so sure how many facilities have psychologists, but I know if it's a center of excellence, we should have a psychologist. Even social welfare, most of the time we just have to refer. But I will ask Matildah to respond if they have a psychologist, a social welfare, a nutritionist, and a psychiatrist, and a clinical team to take care of this person. I know they have cervical cancer screening services, and this girl was managed at a pediatric center of excellence where we do not have the specialties that have been mentioned, but there's a team that is able to link the adolescent to the services that they need through the OVC services. So yeah, that's the feedback I can give. I don't know if Matildah has anything to add, or Dr. Simpungwe, if you have anything to add concerning a multidisciplinary team at a facility in managing such an adolescent.
Dr. Manzi, can I add something?
Yes, go ahead, Prudence.
Okay, so for the multidisciplinary team, we do have in the facility. So we have clinicians, we have even adolescent focal point persons. We also have counselors, peers that are trained in adolescent-friendly services. We do have I don't know if he's a psychologist or a psychiatrist, but there's someone who deals with mental health issues also that we're able to refer to. We do have a nutrition in place and all these, so we're able to do. And also sometimes we do get help from CETA that are also invested in mental health. So I would say we do have a multidisciplinary team, and we're able to refer to the specific, and if it's beyond us, we still have we're still able to refer outside as well. And then for the cervical cancer, I've seen a question on the cervical cancer to say whether we're making follow-up on the query ICC. So in my presentation, when we did the screening, because when she was sent there, they were questioning, there was a query to see maybe she might have cervical cancer. But when she was taken there, we just found that she only has precancerous lesions. And they treated her for that, and she's still being reviewed. So she came for her 1-year review, and she's going to come. She was supposed to come back after, because the next review was showing that the lesions were treated. So she was supposed to come back after 2 years, but the cervical cancer team decided that because she's young and all the things that were surrounding her, they decided to review her a year later. So she's coming back after a year again from the previous. So we're still following up on that just to make sure that she's okay. Thank you.
Thank you so much, Prudence.
With regards to...
Yes, Dr. Simpungwe, can go ahead.
Multidisciplinary teams, I think maybe Lusaka may have that luxury of having so many health workers and specialists in a facility. But what we have realized as a program is that most of these facilities, especially in the rural districts, are manned maybe by 2 or 3 health workers, maybe a clinic officer, a midwife. So there are gaps. And what we are recommending is that let's have databases. I don't know if I can call them a directorate of a directory of other service providers within the communities. So if within that a particular district, you know that we have someone who can provide the mental health services, we can have contacts readily available so that we are able to refer, maybe even sometimes even consult. The way we are communicating now across the country, why can't we also make an effort maybe to call some mental health providers to guide us on what we should do with this particular adolescent with mental health problems. We are in discussion with UNICEF and the mental health coordinator at national level, Dr. Francisca Bwalia, to come up with a training package for frontline workers to provide basic mental health services. And our agreement was that once this cadre is trained, they will be linked with some expert or some consultant, and they will be guided step by step. In case they are dealing with a complicated case, they'll be guided and maybe necessary referrals made when required. So UNICEF will support us to develop a training package for health workers to be trained in mental health counseling. Funding have been secured. The team is ready to come up with that package. So we are excited about that, and we hope that other partners can also take that challenge and train service providers across the country, at least to have even 2 or 3 in a district who can provide mental health counseling. So again, social welfare officers are in our districts. We can contact, we can call. We make an effort as health facilities to come up with a database. Who is providing CDF, who is providing social services, social cash transfer services, who is providing mental health services. So I think we need to maybe do more to come up with that list of service providers, even GBV, the police, victim support, that we should have at facility level so that at any given time, we know who to contact when we are faced with a problem that require support from service providers outside the health sector. I submit.
Thank you so much, Dr. Simpungwe, for that. And for all the contributions, I think we've responded to the questions. There is need for a database for who is providing what services for adolescents. And I think that will respond to the second question that was asking about how can we ensure that adolescents are accessing services. If people know who's providing what services, then they'll be able to link the adolescents to those services. In the chat, I think we've also seen that it's important to incorporate palliative care as one of the components of services that are provided when we make a diagnosis for a lifelong illness such as HIV as well as cancers. We appreciate all the contributions. At this point, I think we've gone beyond 16. I'll just allow if there's anyone from the team of experts who would like to give any additions before we can close the meeting. Please go ahead, Dr. Bupe Musonda, Dr. Robert Banda, Mr. Ntula Simwinga. Yes, Dr. Banda, you can go ahead in 1 minute, just give your comments.
All right, good afternoon, network. Thank you so much. I think this has been a very interesting and fruitful discussion. My contribution, I think, is just on the question that was talking about how we can ensure that we have comprehensive adolescent-friendly services, be it in government institutions or private institutions. I think it starts with us. Of course, the government institutions are the ones that have the largest coverage around the country. And we need to ensure that there is this continuous capacity building in terms of provision of adolescent health services to healthcare workers. However, since we also have a document, which is the Adolescent Health Strategic Plan, we need to ensure that the dissemination doesn't only end up in our government clinics and facilities, but we need to ensure that the private facilities are also privy to this and it's disseminated to them. I think a lot has been said by Dr. Simpungwe, and some of the issues I'll ride on what has already been said. I submit.
Thank you so much, Mr. Ntula. In just 30 seconds, you can give your comment.
Thank you so much. And I also wish to extend my appreciation to the leadership from Ministry of Health. I think I wish to just comment on the multidisciplinary approach. I think in the initial phase of the presentation from Dr. Simpungwe, she mentioned of limitations in resources. I think those are issues which are ongoing and they cannot be addressed like today or yesterday. What I would recommend is that their partners, a good example is Morehouse School of Medicine. They're utilizing telemedicine. I think this has been very useful in terms of overcoming any limitation of not having a full team at facility level. So these technology can pull resources, human resource from various areas. You can pull a psychologist, a psychiatrist from Chainama or any central hospital, and telemedicine can connect those patients with specialists and healthcare professionals remotely. So this will allow for consultation and even collaboration and even access to expertise and reduce the cost on the turnaround time to address issues by the client. So what we want to aim at is how can we improve patient care, expand the reach of medical expertise, and also ensuring a more comprehensive approach to healthcare service, even in settings with limited access, as remote as maybe in Angoma or elsewhere. So, however, it's essential to ensure that we pull resources from existing partners and also make those services available, and how can they be customized to reach unique populations like for adolescents. Lastly, Madam Moderator, I think it's on the issue of policy. I really appreciate Dr. Simpungwe addressing that comprehensively. But very important, let's go back to the presentation. We cannot wait for policies to address psychosocial issues or even Ministry of Justice at community level. Children won't wait for somebody to say, no, a policy hasn't been passed, I can't have sex. So what is it? What are the minimum standards that have been presented and provided for us to address and to ensure that we are able to cater for those problems at community level? That's my submission. Thank you so much for this opportunity.
Thank you so much, Ntula and Dr. Banda for the remarks. Dr. Musonda, are you still on the call? If you are, you can give us your comments on the discussion. If not, I would like to thank all of you that logged into this tele-echo session for the interactive session and all the submissions that have been made. Let me also thank Dr. Simpungwe for finding time from a busy schedule to share with us these wonderful presentations on service provision for adolescent health in our country. We look forward to seeing you next week on Monday as we have another interactive session. Have a happy independence and a lovely week ahead. Thank you and bye.